Good afternoon. I am Dr. Amna, Veterana Fellow, Mayo Hospital, Lahore. Today I will be talking about my work, which is effectiveness of different techniques of removal of silicone oil in decreasing residual silicone oil droplets. Silicone oil, introduced as an internal tamponading agent, is now used in complex vitreoretinal surgeries. It is typically removed within 6 months following surgery. Complications that can occur with silicone oil are glaucoma, hypotony, cataract, silicone oil emulsification, or keratopathy. There are different techniques for removal of silicone oil. Some are passive methods, some are active methods, some are manual, and many more. Earlier studies gauged the efficacy of silicone oil removal techniques indirectly by looking at side effects resulting from residual silicone oil droplets, probably because of difficulty in quantifying residual oil droplets. It is in every patient. Written informed consent was taken, counseling was done, history with demographic information, slit lamp examination, intraocular pressure, fundoscopy, or axial length was done in all patients. A 3-port sclerotomy with 23 gauge trocars were made. Balanced salt solution was allowed to replace globe volume as silicone oil is being aspirated. The bulk of silicone oil was removed from the sclerotomy site. After this bulk removal, patients were divided into 2 groups. A fluid air exchange group, in which 2 to 3 fluid air exchange cycles were done, and oil fluid exchange group, in which the vitreous chamber was washed continually with infusion fluid for at least 3 minutes. B-scan was performed within 7 days of surgery or when the air is absorbed. To remove observer bias, a total of 3 B-scan images were taken and mean was used. Now, to quantify the residual silicone oil droplets objectively, a binarization method was applied to B-scan images using color threshold mode with the help of ImageJ software. Now, what is this ImageJ software? ImageJ is an imaging processing software that is heavily used by artificial intelligence. It has superb competency of discerning features, which is why we have relied on it. So, let me give you one example. This is a picture of B-scan image of a patient who just had removal of silicone oil. You can appreciate residual oil droplets in it. With the help of this ImageJ software, binarization of the image to highlight signals from residual oil droplets in color threshold mode. Now, the vitreous cavity area was demarcated. Now, this software gives us the exact number of residual oil droplets and area of each droplet. After this, silicone oil index was calculated, which was the sum of silicone oil droplets area to the area of the vitreous cavity. Now, I'll show you my results. The main part of my result is silicone oil index of fluid air exchange is much lower as compared to oil fluid exchange. So, according to our research, fluid air exchange is found to be superior as compared to oil fluid exchange. We also see correlations of silicone oil index with ocular parameters, and it is strongly correlated with preoperative intraocular pressure or axial length, and it is not correlated with age or gender of the patient. To further elaborate our results, silicone oil index in air fluid exchange is strongly correlated with preoperative intraocular pressure, duration of silicone oil tamponade, and postoperative intraocular pressure. Silicone oil index in oil fluid exchange is strongly correlated with preoperative intraocular pressure, postoperative intraocular pressure, axial length, and duration of tamponade. So, our results show that fluid air exchange is found to be superior than oil fluid exchange. What is the reason behind it? In supine position, when air is injected, silicone oil collects in the macula and forms a thin layer between the balanced salt solution and air. A backflush cannula inserted at the level of this oil BSS interface can easily extract all the silicone oil. Another location for small silicone oil residual particles is the retroiridal plane. Flow of air can dislodge these and make the removal possible via the backflush cannula. So, our results show that silicone oil index is strongly correlated with duration of silicone oil tamponade. Some studies have shown that IOP returns to normal range after silicone oil removal. We do see a persistent raised intraocular pressure after removal of silicone oil in both groups, but it is far much lower, that is 17% in fluid air exchange and 55% in oil fluid exchange. No redetachment in the fluid air exchange group was noticed, whereas 2 cases were seen in oil fluid exchange group. So our study is the first in Pakistan to quantitatively measure the residual silicone oil droplets. In the end, I would like to conclude that fluid air exchange is the preferred technique as it decreases residual silicone oil droplets, so decreases silicone oil related complications. Less number of patients reported increased intraocular pressure after fluid air exchange, and no case presented with redetachment after fluid air exchange. With this, I thank you all.
Thank you very much. Any questions from the audience?
मल्सीफाई होने के बाद सम टाइम इवन विद फ्लूइड एक्सचेंज के बाद फिर वो सरफेस के ऊपर सारे बबल्स एक्यूमुलेट और अंडर द आईआरएस भी पड़ा होता है, तो हाउ विल मेक श्योर कि ये अभी जब आप एयर फ्लूइड एक्सचेंज करते हैं, एयर उसमें छोड़ देते हैं, 2-3 दिन के बाद या 4 दिन के बाद जब वो दोबारा फ्लूइड आ जाता है तो फिर उसमें आपको बबल नजर आते हैं, हाउ विल मेक श्योर कि ऑल द मल्सीफाइड बबल्स आर रिमूव्ड?
सर, जो से 3 साइकिल्स की थी इसमें हो गया, आई शो द these can measure specifically हमने क्वांटिफाइड किया रेजिस्टर ड्रॉपलेट्स को और इमेजेस ऑफ
वापस उधर ले आइए, सॉरी।
उसने भी ये कहा कि किसी बहुत कम केसेस में हमें बिल्कुल पार्टी में ना उसमें भी थोड़े बहुत थे, बट
आपने ARN खोलना, ये इससे नीचे ये वाला,
बिल्कुल खत्म नहीं।
इसको स्लाइड शो ले आना, स्लाइड शो बस ठीक है।
This is very encouraging. There are no revenge period. None of the cases. Revenge recurrence period. ये तो कितने केस है?
61
that is very good.
So मेरा तो 10% रेट है सिलिकॉन
At
ऑयल
the end you use the air. It is came to the air छोड़ते हैं कि fluid या mix.
जो फ्लूइड एक्सचेंज में था उसमें एयर छोड़ी थी, दूसरे में fluid था।
It's a completely fluid.
Can I ask you one thing? आपका जो the software which you used, image J जो आपने mention किया है, उसके ऊपर जो marker you were using for the oil droplets, my impression is oil droplets should be in a spherical circular form. वो बड़ा linear सा उस पे आ रहा था। आपके जो dots
सर
आते हैं,
सर्कुलर फॉर्म में नहीं होते, हमने जितने इमेजेस किए हैं कोई भी
do
सर्कुलर
you think कि वो clumps बने हैं, multiplied clumps होंगे? So our next speaker is Dr. Ruba. She is a resident in Al-Shifa and she is giving a talk on the hepatic retinal necrosis cases.
Good afternoon and Assalamu alaikum everyone. I am Dr. Aruba Zafar, and I'm a fourth-year resident at Al Shifai Trust Hospital, and I'm very grateful for the opportunity to be speaking at this forum. Today I will be speaking about the disease spectrum of hepatic retinal necrosis. Is it better? So the purpose of my discussion today is that I'm going to walk you through a few clinical scenarios, and then I'm going to be discussing the diagnostic criteria and treatment guidelines of hepatic retinal necrosis. For an overview, ARN is a rare and blinding pan-uveitis that presents with occlusive vasculitis and peripheral retinal necrosis. Our first case was a 40-year-old male medical professional who presented with unilateral blurring of vision for the past 2 weeks. He had a recent history of chickenpox, which was complicated with pneumonia requiring hospital admission. On examination, his vision in the affected eye was 6/24, and his AC had non-granulomatous scabies and cells were +2. On posterior segment exam, we found vitritis and large foci of peripheral retinal necrosis. This was the wide field image of the patient's affected eye, and it shows an area of fluffy whitish retinal lesion temporally with surrounding inflammation. This was the FFA image of the patient, and this area of necrosis and non-perfusion corresponds with the lesion. So our first step in this patient was to do an AC tap for suspected BZV infection, and immediately after that oral voriconazole was started at 2 gram oral TDS for 14 days. So voriconazole is not available.
It's val-acyclovir, not voriconazole.
Oh, I'm sorry, this is my mistake. This is val-acyclovir. I'm very So oral val-acyclovir was started at 2 gram PO TDS for 14 days, and then after 3 days it came out positive for BZV, the AC tap. So this is the patient's picture after 6 months. For 4 months he was continued on the val-acyclovir, and 6 months later you can see that his retina is attached still, and the lesion has not progressed centrally, and there seems to be some subretinal fibrosis. Our next patient was a 77-year-old male who presented with blurred vision unilaterally and had a recent history of shingles. On examination, his vision unfortunately was hand movements, his cornea was clear, his AC cells were +2. On posterior segment exam, there was total retinal detachment with supratemporal large necrotic area with multiple large breaks. Unfortunately, we lost the image that we initially had of this patient. Our treatment plan was IV acyclovir for 10 days, and he was sent to Shaukat Khanum for this treatment, since oral is available with us but IV isn't. And then we kept him on oral maintenance therapy, and the next immediate thing we did was PPV with silicone oil. So this was the image of after silicone oil installation. You can see the extensive area of retinal necrosis. And 2 months after silicone oil removal, you can see that the retina is still attached, and the patient's vision did improve somewhat to, I think, 660, I believe. Our third patient was a 35-year-old male who was HIV and HCV positive. Unfortunately, the patient was very unwell when he presented to us. He was debilitated, and he presented with painless loss of vision and floaters in both eyes. This was the fundus image of the patient, where he had this extensive necrotic areas and hemorrhages involving the posterior pole as well. So I'll come towards the diagnostic criteria of the American Uveitis Society. There are 6 main points, and those include single or multiple areas of retinal necrosis with distinct borders. The necrotic foci usually are located in the peripheral retina, and there is rapid disease progression if it's not treated immediately, and it tends to spread circumferentially around the retina and then comes towards the center at the posterior pole. And there is presence of occlusive vasculopathy with arteriolar involvement, and the inflammation in the AC and the vitreous can be marked. Now I'll discuss the NICE guidelines for hepatic retinal necrosis. The first line is oral val-acyclovir 2 gram TDS for 10 to 14 days in the acute phase, and then maintenance therapy, which is 1 gram TDS for 12 weeks. Oral steroids can be used if they're required, and they can be begun about 48 hours after instituting viral treatment. And if the lesions involve the posterior pole, we can also emergently give intravitreal foscarnet 2.4 mg in 0.1 ml. The second line treatment that we can go for is IV acyclovir 10 mg per kg TDS for 7 to 10 days in the acute phase, and then oral maintenance therapy of 800 mg 5 times per day for 12 weeks, and oral steroids once again if they are required. So the key things that I would like to highlight over here are that ARN is a very fulminant infection, and it can very rapidly spread and circumferentially and then involve the posterior pole, and it is sight threatening, and if treatment is not instituted, the patient can go blind. The second thing is that AC-TAP is a very important diagnostic tool, which is, I believe, underused in our setups, and it is simpler to perform. It may be a bit expensive for some patients, but I think it is utility in our treatment decisions. The third thing is that in our country, adequate treatment may not be available to most of the patients, and this is one of the problems over here. I especially acknowledge Dr. Mohammad Amjad and his teaching of these cases. Thank you very much, Sir Amjad. Thank you.
Thank you very much. I'm not a senior consultant. Anything from the audience?
I think immunocompetent भी क्या dosage है oral well acyclovir? It's 1 gram or 2 gram?
2 is.
If this patient was immunocompromised, HIV.
सर HIV का जो पेशेंट था, अनफॉर्चुनेटली डीजी खान से था. डीजी खान में कोई सेंटर है HIV का, भी रिफर्ड बैक है. अनफॉर्चुनेटली डाइड विद इन 2 weeks. तो उनको they were going to start the IV treatment HIV
इसके साथ हार्ट थेरेपी भी साथ चल रही है, और
उन्होंने अभी स्टार्ट की है सर.
हार्ट थेरेपी के साथ आप ये भी साथ देंगे या वही?
नहीं सर, उसके साथ देंगे सर.
Okay.
मोस्ट लाइकली गैस साइक्लोविर को the option CMV retinitis होगा उसमें most likely. We couldn't follow up, he didn't come back to this.
ये चीज़ बहुत इम्पोर्टेंट जो ये है कि when you treat these patients जो आपने present किए, they are critically ill patients.
Especially the HIV one.
तो मैं हमेशा focus करती हूँ point पे कि there are lots of things that we ophthalmologists have to do, and there are lots of things that we need a coordination of as a team. So when you're presenting and you're सवराते कि हमें इसको ये इतनी dose देनी है 1 gram 2 grams वगैरह, I think it's very important to realize that we alone can't do that. We need a team who will be looking into the toxic factors of these medications, because if them for 10 days you this IV lines are taken, or the straight जो renal profile, liver profile, ये सारी things have to be taken care of. I think this presentation is a beautiful presentation, but if you could highlight कि how was they ये चीजें जो आप manage करें.
Practical issues जो हमारे साथ हैं in terms of the uveitis, we had a previous session जिसमें बड़ी detailed discussion हुई थी. We always work in liaison with the rheumatologist and infectious disease. We are very lucky to have both these.
This is a very lacking
In our country,
in our country
especially.
infectious diseases
बिल्कुल.
क्योंकि ये चीजें जितनी भी हैं अकेले संभालना भी
Yes.
इजी टू से कि हमने इसको ये जो है ये मेडिकेशंस आईवी लाइंस दे दी नॉर्दर्न वगैरह, लेकिन उसके बाद when you giving them what havoc is it creating into the rest of your body has to be taken care of. And
Exactly.
here I think it's always good to have a slide of
Yes.
the infectious diseases people के जी वो कैसे मैनेज हो रहा था,
बिल्कुल.
क्योंकि यूवेरिटिस मोस्टली तो आपका अकेला तो आ ही नहीं रहा होता. This is a
The other practical issues जो हैं, the tests are very expensive. AC-TAP we usually do on the straightener, or the cost for one single viral PCR is about 5 to 6,000. लेकिन कुछ हैं शुगर खानम या चौथाई वगैरह, वो तीनों CMV, VZV and PPV तीनों को करें 15,000. So the cost is high. The other issue we get is with the treatment side is the well acyclovir. जो पहला patient था हमारा orally was well off, medical background था, तो वो टर्की से मंगा रहा था.
लेकिन मेरा भी कुछ सेंटर पे अवेलेबल है.
नहीं सर, oral नहीं अवेलेबल है. तो he was getting it from Turkey, और उसको cost उसको 50,000 की cost पड़ रही थी per week.
So we had a patient,
फैन
he needed 900 mg का सिर्फ floating dose for 2 weeks. So
Interestingly, Shaukat Khan, they got GAN cyclovir, cyclovir recorded, and it's very difficult to get from that.
lucky about the medicines.
And his vision did improve as well.
And improved also.
I think it's very method patient treated as patient as a whole. So इसकी early recognition of this entity, necrosis is very important because treatment management you have to different है. If you treat it like related, non-related, personalized affair, you start immediately you see that person with condition. You have this thing in mind, and if you get viral immediately it will be viral available and viral available. After you start that, even after 2-3 days के बाद आप 48 hours के बाद you can start seeing that.
But you see the differential diagnosis takes us straight to the था कि आपको क्लिनिक के साथ इसको रूल आउट करवा दिया पहुंचे आप लोग.
The first patient जो था, he was seen by other centers. हमारे पास आया था within a week. So it was initially देखते हैं when we started treating straight away.
उसको नजर आ रहा था किसकी
उसके आप पहली ऑक्टोस की पिक्चर देखें, it's very clear.
Acyclovir तो अवेलेबल है. अगर आपके पास नहीं मिल रही तो सेकंड चॉइस इज Acyclovir.
Acyclovir is available. Orally, IV is not available. Oral easily है, लेकिन compliance issue है, और secondly if you
Dose
face
LS की 5 times a day. 5 times a day. 800 now. उसकी dosage.
और secondly retinal necrosis की other भी differential है, but when we went into the history, उसमें present किया, बताया हमें कि last month he had a chicken pox and he was admitted in the hospital. So we only checked for the VZ, we rather checking the whole viral PCR. So
and luckily take care of it.
yes.
So
Drawing the
most
other
important
teacher,
है
they make it positive.
clinical evaluation, clinical आपके बिल्कुल सही है. Clinical interpretation becomes the first thing. जब आप DBs and all that पे जा रहे थे, जो आपने देखा तो आपको rule out करवा देते थे तो पहुंचा देते थे.
Thank you very much.
Thank you, sir.
Next presenter, we've got Professor Masayo.
Sir, my apology, this is not a presentation, this is a video. Like I said, today the video is not going to be but you're relying on the rest of our.
Thank you very much.
इसे भी I think बोल के थोड़ा सा change होना जरूरी होता है.
Sir, while she's setting up the autopsy pictures were taken without the they were undilated images. Autopsy.
चलो ये हटा दें.
Soon we are getting next month, hopefully, or
इसके ऊपर रख दो.
or the one we are getting will be having the OCT module as well. ICD we are progressing here.
Okay, so Assalamu alaikum and thank you for inviting me here. And today, what I'm going to present is a nice video of how intraocular foreign body can be taken out through the corneal route, and with the presence of lens capsule. So most of the time we use the scleral route, or if there is a phakia or there is a rented capsule, so we use the corneal route, but we can still make a way and take it out through the anterior capsule. So in a way it's a self-explanatory, but साथ में अगर बोलने का अगर ना भी बोलूँ तो I think चलेगा. So here we go. A young boy, as usual, we have these issues of metallic foreign bodies piercing the eyes. Sometimes they are working, and sometimes. इसमें music नहीं आ रहा जी. Can we have the music, please? Music नहीं है, all right. So you can see there are sidrosis के anterior capsule के ऊपर there are brown marks. So ये pickup क्यों नहीं हुआ था? Nobody knew कि sidrosis. When I looked at this, यहाँ पे foreign body has to be inside the eye. So ये जहाँ से आया था, so just he had uveitis, inflammation, AC reactions, and these made us realize that we need to go and investigate. And we just got a B scan and a CT scan and found it told us where the foreign body was. So the patient, the child didn't know. He had this issue a few months ago, and now his vision was dropping. So the first thing was take this soft cataract out and try to remove these little sidrotic anterior capsule spots or dots as much as you can, because these can lead to a little bit of reaction post surgery. So following that, the viscoelastic was injected, the AC, the posterior capsule is intact, and right now it was better just to close the wound
so that the second part of the surgery, it was not a 2-stage, but it was a 1-stage surgery because I prefer doing that. So kar hi rahe hain, so might as well go and work it together. There can be questions as to why the ports were not made before or after. Usually I make the ports before, but sometimes when you're teaching your students also, you're watching and all that, you can show them that it can be done both ways. So 23 gauge pars plana vitrectomy ports were made, and then the vitrectomy was started. First thing important was, and you can notice that's a nice interior capsule, there's a capsule bag present. So first thing was to identify the foreign body as to where it was, and for that we had to indent. It was in the peripheral retina, we had to indent, and as I was not taking foreign body forceps inside because it's of a larger size, so I used a micro end gripping forceps to dislodge the foreign body with peripheral indentation taking place at the same time. So just brought it down, and then the route of removal was from the posterior capsule. So I used a radio frequency probe to make a small posterior capsulotomy. You can use with your cystotome also, but when you're using that, you can actually damage the zonules also. So if you have the facility of a radio frequency probe, it will make a very nice small posterior capsule opening. Do a little bit of anterior vitrectomy if you feel there's something is left behind, and then use that to remove the foreign body. So it was picked up by the end gripping forceps, and then it was gently taken out from that posterior capsulotomy that was made and moved into the anterior chamber of the eye. Now it's a big size, it's not a small foreign body. It's ragged margins, it's metallic, and it has a coagulum around it showing that it has been there for a while. So then you can, at this time you should take a breath. It looks very easy. You need to take a breath because this big foreign body has to be moved over and taken out from the phaco incision. I didn't want to extend the phaco incision, so you take your time. So once it's moved, brought close, just pick it up. Looks easy, it's not. So use the probe. It looks easy, but it's not.
The removal is easy, but the movement inside the ACL was
Absolutely, because of the record. Because these are projectile forced into foreign bodies, they cause a lot of structural damage along with it, which is known as the ricotic movement hoti hai, and it causes a lot of problems with it. So after that, I used the bag and put a single piece intraocular lens using the bag because it was a very small radio frequency posterior capsulotomy done. And so once the foreign body was, intraocular lens, a multi-piece, which is available in the hospital, we didn't get anything from the patients. So in our hospital, we provide them with everything, and that is, I think, a blessing in disguise. कि vitrectomy हो रही है, सब कुछ हो रहा है, you don't charge them. They come with the 10 rupee admission slip only. So following that, I completed the vitrectomy, and there was heavy liquid there, which we took it out. There are certain things to make. Endolaser has to be done in the area where you've taken the foreign body out. So once you've done that, I did not leave it into air. I believe that leaving silicone oil tamponade is better because it has got its antigenic properties also. It helps in maintaining, and because the foreign body was lodged in the superior retina, so it was easy for us to take it out. So that is the post-operative view of the retina. Looks easy, man, it's not. Thank you. It was the child came to us after 2-3 months. हमें खुद नहीं मिला कि कहाँ से था, क्योंकि उसको he didn't know he had a foreign body inside. I brought this because if that sidrosis was not there, और वो क्योंकि superiorly impacted था, उसको indentation के बगैर तो नज़र ही नहीं आई थी. He had not had a CT done, he had not had a B scan done, so he was fine. It was 2-3 months later when he had this inflammation going on, his vision was dropping. That's when he came for review. और अगर वो sidrosis ना होती तो I'm a human being, I would have made a mistake. I would have said there's nothing wrong क्योंकि indent तो मैंने इसको शायद ना ही किया होता. So that was thing, and then I called all my trainees and I said, I didn't tell them, I said, there are these things, क्या हो सकता है? And then we started all over again, and we took the foreign body out and नज़र ही नहीं आ रही थी. So I think it's very important for the trainees to look for signs of cirrhosis, और अगर कोई कह रहा है कि vision drop हो रही है, because this child was a bystander. ये वो वर्क तब पे 15 साल का बच्चा काम नहीं कर रहा था, वो bystander था. कोई चीज़ लगी, किस एंगल से लगी, हमें आज तक wound of entry नहीं मिली. So that was amazing. बिल्कुल ये देखिए कोई इन्फ्लेमेशन नहीं, कोई वो नहीं. इसकी विजन जब वो इसकी तो विजन अभी तो सर सिलिकॉन ऑयल था ना इसके आंख, तो ये अभी दिस इज़ अ रीसेंट थिंग दैट उसके ऑयल तो हम छोड़ेंगे एटलीस्ट 3 months के लिए. सो उस वक्त जब था द चाइल्ड वुडंट बिलीव दैट यू नो देयर इज़ अ फॉरेन बॉडी. एक्चुअली वी ऑलवेज डू वन थिंग. जितनी भी फॉरेन बॉडीज़ अभी तक मैंने निकाली हैं एंड दैट हैज़ बीन सिंस 2005-6, वो मैंने सारी संभाल के रखी हैं. सो आई हैव सर मेरे पास इस वक्त 48 फॉरेन बॉडीज़ इंट्रोपल फॉरेन बॉडी जो मैंने निकाली है एंड दैट आई एम गोइंग टू प्रेजेंट इन अपाउ. वो मेरे पास एक है बिकॉज वो मैं एविडेंस के तौर पे अपने पास फॉरेन बॉडीज़ अपने हॉस्पिटल में रखती हूँ, उनको दिखाते हैं कि ये निकला आपकी आँख से, ताकि यू नो इतनी छोटी दे वोंट बिलीव यू. उनको होता है कुछ भी कर रहे हैं, फिर नज़र अगर ख़राब हो ना ठीक हो. सो देयर लॉट्स ऑफ एलिमेंट्स दैट वी नीड टू लुक इनटू. सो ए पीस ऑफ एडवाइस, इफ यू टेक अ फॉरेन बॉडी आउट, कीप इट, बिकॉज सोवेनियर के अलावा यू माइट बी टेकन टू कोर्ट समडे. यू शुड हैव इट. नहीं सर वो मेरी प्रॉपर्टी है, वो मैंने निकाली है. ठीक है. Yes. They were on the anterior capsule. They are like small granules की तरह के pigmented जो होते हैं ना क्या ferric changes जो आती हैं उसमें, वो पड़ी हैं. वो अच्छा strangely the retina पे नहीं थी, क्योंकि this had this. और मैं ये चीज़ हमेशा नोट करती हूँ, if it is a large size foreign body somehow it gets impacted in the peripheral retina. If it's a small size foreign body वो सो जाके ना यहाँ पे या तो सेंटर मैकुलम में जाती है, विट्रस में रुक जाती है. यस यही तो हमने पिक किया. हमने तो आज तक देखा ही नहीं कभी इतनी खूबसूरत तरीके से सिट्रोसिस आपकी पड़ी हो. एस्पिरेशन के साथ जितनी मरता निकाल सकती थी निकाल दी, बिकॉज पोस्ट ऑपरेटिवली ये अगर आप इसको छोड़ें, दिस इज़ ऑल्सो अ लिटिल बिट ऑफ आयरन करके, तो वो आपको मजीद इन्फॉर्मेशन कर सकता है. सो इट हैज़ टू बी लाइक पॉलिश्ड. यू हैव टू डू इंटीरियर पॉलिशिंग ऑफ द कैप्सूल. You take everything out and then you proceed with the vitrectomy. You shouldn't leave these little. Sometimes you even have to look for ये जो होता है ना कि foreign body जब आप निकाल लेते हैं, छोटे छोटे simple chunks जो होते हैं coagulum के, वो भी जो पड़ते हैं, you have to take them out also. You can't leave them behind because post operatively uveitis करेंगे, सर के पास पहुँच जाएंगे. जी जी सर, सुपीरियर रेटिना में बेबेरे था. सब ट्राई नहीं की सर, उसको स्क्लेरल इंडेंटेशन करके उसको निकाला और लेज़र कर दी फिर साथ में. ट्राई भी कर सकते थे बट वो लेज़र के साथ जब उसको आइडेंटिफाई कर लिया फिर हम लेज़र तक पहुँच ही गए थे सर. सो
I'm a fourth year resident from Karachi, Jinnah Hospital, and just want to share something with these patients a lot. And I'm sure my experience will be peanuts for
नहीं आपको यू विल बी सरप्राइज कि आपके कितने हमें फ़ायदेमंद रहेंगे हमारे लिए आपके एक्सपीरियंसेस.
One thing that we do in our center whenever a patient comes with a suspected foreign body, in this case you're not sure, but whenever there's a patient who comes up with us, we have a CT scan with multiple views, which engages much more than we identify the patient.
Okay.
So afterwards we stick with a piece of oxide or foreign body discharge card as a proof to the patient, and they keep it like safe with them. So this is something.
भाईजान मैं तो नहीं दूँगी, इसलिए क्योंकि ये तो मेरी प्रॉपर्टी है. किया किसी ने निकाला, मैंने वी शो इट टू देम. आजकल टेक्नोलॉजी आ गई, दे टेक पिक्चर्स, यू नो, दे टेक पिक्चर्स, दे हैव द एविडेंस. द वे थिंग्स आर गोइंग, यू शुड हैव योर डॉक्यूमेंटेशन विद यू. ऑडिट होना होता है बहुत सी चीज़ों का, राइट. ऑडिट के पॉइंट ऑफ व्यू से आपको कुछ चीज़ें अपने पास रखती हैं. सो वो मेरे पास नहीं है, इट इज़ अ प्रॉपर्टी ऑफ द आई थिएटर. सो उनकी जो होती है पूरी बुक होती है डिस्चार्ज इट्स ऑपरेटिव नोट्स की, उसके साथ वो अटैच्ड है. So it becomes very easy for us, and that is why I'm writing a paper article, sir. The writing of all the intraocular different shapes, their sizes, and the structural damage they're causing. Because vision तो सारे देख रहे होते हैं, but looking at the mass and looking at the shape sizes, उससे भी बहुत पता चलता है कि किस level तक ये आपकी size से पता चलता है कि how far the speed is and how far it will go. But the beauty of this case was nobody knew. He didn't know, we didn't know. He had been shown to other people. They didn't know because probably the cirrhosis had come just now, like a couple of days, and the patient came कि मेरी vision drop कर रही है. अगर वो cirrhosis ना होती, there is a possibility that we might have also missed it. सारे cases को हम CT scan नहीं करते. जी सर. Sir, सर कुछ तो हम इनसे लेंगे, ये जो तारीफ मैं लूँगी, हम लेंगे, हमारा डिपार्टमेंट लेगा, क्योंकि हमने नाक में दम किया हुआ है MS और इंस्टीट्यूट के. वी आर द ओनली वंस इन गंगाराम जिसका टेंडर और जिसका होता है उसमें हम खुद पर्सनली बैठे होते हैं, और हम सब कुछ जब तक उनसे निकाल ना लें हमें सांस नहीं आता. So we get the vitrectomy cutters and the cassettes and the provincial, the जो hospital का fund आता है उसमें से हम they like us, I guess. So thank you so much.
A question about the diagnosis, how when diagnosing these intraocular conditions, you just rely on X-ray for it, or you definitely go for a CT
बेटा एक्सरे तो पुराने ज़माने में जब मैं करी थी ना PG शिफ्ट, तो तब एक्सरे और उसकी फिक्सिंग और वो जो है आयरन लगाया हुआ, तो उसको किया हुआ कि ऊपर देखो नीचे देखो दाएं. अब नहीं करते हम. मुझे तो नहीं याद कि एक्सरे वगैरह मैंने कब किया.
but still, I mean, you have to still go for
Let's live in the present and let's go, and you are the future, so let's stick to the CTs and God knows what else is coming up. ठीक है, एक्सरेस तो मुझे भी याद नहीं. I wouldn't waste my time on an X-ray.
I agree with this. CT scan. I think we don't have Dr. S anymore, so we'll move on to the next presenter, Dr. Usama Iqbal. मैडम, हमारे पास रेडी टू कैंसी कैप्सुलोटमी नहीं होगा.
नहीं हमारे पास तो है ना, RT में है ना,
RT में है ना,
RT में है हमारे पास.
सर pediatric में इस्तेमाल होती है.
दोनों
सर एक तो pediatric में जो बड़ा इलास्टिक है, और जहाँ पे
इसको
आप
कहते हैं HF कट के नाम से आते हैं, हाई फ्रीक्वेंसी
बाहर
कट.
ना करें, बढ़िए इससे निकालें. जी सर, O3 में.
कटर बड़ा अच्छा है.
लेकिन एक और ऑप्शन है कि आप स्टील कैप्सूल वैक्सीन भी कर सकते हैं कि वो आपके वीलॉन है, वो इनसाइड और उसके बाद आप उसको बड़ा आसान.
आप पीछे से लेंसेज के साथ भी कर सकते हैं. लेंसेज जहाँ बना था वीडियो में एक ही काम है.
पास प्लान
तो उसमें लेंसेज के साथ लेंगे कैप्सूल भी कर दिए.
I am Dr. Usama Iqbal, and today my topic of presentation is smartphone fundus photography, which is in fact a narrative review written by me. These are disclosures of my presentation. This article is my own work which is published, and all the pictures presented are taken by myself, and all the pictures are according to HIPAA guidelines. I have no financial interest and no competing interest. This is the information about my article, which is published in International Journal of Retina and Vitreous with the impact factor of above 2, and this is a gallery view of it. Basically it is a review, so I will be discussing just highlighting points relating to it. The art to image the retina has been of great interest from the ophthalmologist, and the optics of the eye, which are in fact forming the image on the retina, basically hinder the direct photography of retina itself. Talking about history, the idea to take image of the retina was first given by a French physician who observed that if cats are immersed in water, then their retinal vessels become visible. And after that, the first picture of retina was taken by a German ophthalmologist, and first fundus camera on which the current fundus camera is based was developed by Goldstrand, on which the optical model of eye is also based. Now with the advent of high quality cameras and high resolution features of cameras in smartphones, this feature can also be used to take pictures of the fundus, on which first report was published in 2010. And the principle of taking picture of retina using a 20D lens is basically similar to indirect ophthalmoscopy, and this is the optical diagram of it. The illuminating system of a direct ophthalmoscope is in fact replaced by the flashlight of camera, and the viewing system is replaced by the camera screen of the smartphone. The technique is that after pupil dilatation, the smartphone application is opened, and there are different tips related to it. If we go in video mode, then the flashlight remain turned on throughout picturing, and if we have different apps related to it, then it also makes the flashlight on throughout our imaging process. I have tried it myself with iPhone, Huawei, Samsung, Vivo and Oppo phones, and it depends upon the location of camera on the back side of phone. and proximity of flashlight with the lens of the camera. The 20D lens is similarly placed close to the eye of the patient, and smartphone is used to take the photo. This is the description of it, that how phone is held and how the condensing lens is placed over the eye of the patient. The image taken by this technique can be magnified as well as minified by adjusting the filming distance of the camera and also the lens from the eye of the patient. The peripheral retina can be examined by giving a different direction of gazes, and similarly posterior pole can also be examined by giving a target to the patient. Different features of the smartphone which can affect the picturing is, as I mentioned earlier, the location of a lens camera on the backside of the phone and the proximity of flashlight in relation to the camera. And the beginners who are new to this technique can face difficulty, like in picture mode it is difficult to take pictures, so we can move to the video mode, and the glare, which is in fact the reflection of flashlight light from the lens and reflection of ceiling lights of the phone in which photography is done. This is the picture which is showing the glare from a flashlight and ceiling picture image which is seen in the 20D lens. Another problem which is coming is that new smartphones are coming with more than one lens. So if we have 4 lenses on the back side of the phone, we have to identify which lens works in the video mode and in which field of view. So we need to select that lens, its proximity with the flashlight, and use it for picturing the retina. Initially, it was question which is coming to myself, that is the flashlight is safe for the retinal photoreceptors, and I did a literature review on the topic, and one reference which I found which was very much satisfying for me, it was done in New Zealand, and according to ISO standard guidelines, the retinal irradiance which we give during 1 to 2 minutes picturing process is basically 150 times low to develop thermal damage and 250 times below to develop any photochemical action on the retinal photoreceptor. These are few pictures which are taken by me showing different anomalies of retina, the myelinated nerve fiber layers, the myopic fundus and ocular albinism, macular edema, and retinal detachment in different gazes showing macula and peripheral retina, also different retinal breaks, GRTs, U-shaped retinal tears. And different studies which have examined the quality of these pictures with the standard fundus photographs have shown that these pictures are reliable and can be used for diagnosis as well as for teleophthalmology, in which we can send the pictures to our professional colleagues and VR fellows, which can give comments and then we can manage or refer them. So the most important benefit of this technique is that it is cost effective, it is portable. I have used it myself to screen the ROP child going to INICU where facility of fundus camera or even indirect ophthalmoscope is sometimes not available. For teleophthalmology, I use it to give to Dr. Irfan, who is my supervisor also and VR consultant, for documentation of retinal lesions and for teaching and learning purposes in the ward. Thank you very much for your cooperation. Any questions?
Do you use any post-processing for these images?
Yes, sir. Which?
Post-processing. I mean, do you put them in some
no, ओरिजिनल लिए ना उसकी वो कलर्स और वो रेटिना की ओरिजिनल पिक्चर वो भी थोड़ी सी इफेक्ट होती है, इसलिए मैं आई पर्सनली यूज द ओरिजिनल पिक्चर्स. Line position, sitting position, as I have shown in my picture. Mostly I do in sitting position, and even the stool where I examine the patient. It is easy to get the picture. No.
very handy, very cheap, you can keep a record of your patient.
Yes, sir.
You don't have a this camera sitting anywhere, maybe operating
And a good camera. Thank you very much.
Thank you very much. I'm sure तुम्हारी भी बड़ी अच्छी लाइब्रेरी होगी जिस तरह मैडम की फॉरेन बॉडीज की.
नहीं सर के पास हमारे पास एक लाइब्रेरी है और देखिए अपनी फॉरेन बॉडीज की एक गोल्ड की फॉरेन बॉडी
It was very fascinating in the eye when you made him see the board and all that. When I looked at him, वो इतना नहीं था कि मुझे की आँख थी कभी नहीं बैठे बोर्ड में टुकड़ा है
Thank you very much, everybody. Sir, do you mind coming on to the front? Please stay a second.
May I request Dr. Azam to please come forward?
Please. Can I have Dr. Kumar second, please? Dr. Aruba Zafar, please. And can we have Dr. Usama Iqbal, please?
Ramnath?
I'm sorry, I don't know.
These are the
At the speed, you can have one picture.